Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm delighted to be joined by Dr. Amy Baxter. She is a pediatric emergency room physician. She is the founder and CEO of Pain Care Labs and the inventor of the Buzzy device and vibrating. Amy, thanks for joining me today.
Thank you so much for having me.
First off, for our listeners, perhaps you could explain briefly what Buzzy is and what vibrating is.
Sure, kind of cut to the chase. So both Buzzy and vibrating are very high frequency, low amplitude mechanical oscillatory strain devices that incorporate ice. So to break it down, it's a vibrator and an ice pack. But the reason for the specific frequencies and the way we put it together is that we discovered we could block pain using two different physiologic sensations. And we started with Buzzy because I'm a pediatrician for injections, vaccines, and IVs. And over the course of about 10 years of development, found that our users were actually using the same frequency to treat their hip pain and their knee pain, and even specifically to avoid opioids after a knee replacement surgery. So vibrating came from the understanding that if you can block pain from needles, you can block pain from anything. It's the same pain nerve.
Fascinating. You started out, your main career was as a physician. You're an emergency room physician, obviously with a focus on pediatrics. What was it that started you down this journey? How did you end up developing a device?
It certainly was not intentional. The reality is that I had to develop the device as a company because the only way to get funding to study it was to do a small business innovative research grant, and for that I had to get a company founded. And the device part itself, I'd always tinkered with things. But when my son had a bad experience with needles, actually on 9/11, in September 9/11, he became so afraid of doctors that over the next couple of years, I realized this needle fear was going to impact his healthcare. And I played around with the concept of running water that can stop a burn pain. If you burn your finger and you stick it under running water, immediately the pain disappears. If you bump your elbow and you rub it, immediately the pain disappears. So by extrapolation, one night coming home from an emergency shift, I realized that my hands were vibrating on the steering wheel, and I burst into the house. And while vibration alone wasn't enough, when my husband and I put a bag of frozen peas and a vibration unit together, we could block the pain that was sufficient to leave pokes on my kids' hands. You know, I was poking their hand to see if it hurt and poked hard enough to leave marks, and they could not feel it. So that was in 2004. And over the next few years, I experimented with different frequencies, different motors, found out how to put things together, took a lot of cell phones apart, and came up with a device. But by the time I started feeling guilty about being in the emergency room, hearing children crying because of needle pain, and knowing that I had something that I used for my kids that was in my pocket, but it was soldered together in my basement and held together with electrical tape, that was when I decided I had to really investigate if it worked, which required me starting a company to get the funding to do the research. Circuitous indeed.
So it's interesting, you know, the whole pediatric thing, which relates back to my personal experiences. And in fact, my training that was most significant in terms of reducing pain came from a vet. And I spent some time, it was part of my sort of desires. I wanted to be a vet at one point. And we were giving injections to animals. And, you know, I asked him about pain, and he said, well, you know, one of the most important things with animals is that they're unforgiving. If you induce pain, they're going to kick you. And he had a whole technique that I used for years, which was essentially based on the same gate theory of slapping with the distraction that was highly effective in animals and proved to be highly effective. you're essentially doing that, but you've taken two signals in this instance. And is that the critical difference to some of the other activities that are trying to do this in the same kind of way based on that gate theory?
Yeah, the knowledge of how pain works has just exploded in really the last 10 years. I think the best understanding is that pain is the body's opinion of how safe it is. So it's not just the free nerve endings that are spread like a web all over your body. It's also how much attention you're paying to that and where your focus is and how afraid of those sensations you are. So the body is designed to interpret the sensations, to block some of the sensations with the slapping or the gate control of what actually gets up to the brain. And then once it's in the brain, you can influence how it's interpreted. And with the ice, it actually does a feedback loop where it's called descending noxious inhibitory control. So the vibration or the slapping actually inhibits and blocks the pain sensation in the spine from getting transmitted to the brain. But once you transmit certain signals to the brain, they can be interpreted as annoying but not dangerous, in which case the thalamus actually sends descending inhibition down. So then you get this whole double feedback loop of not sending signals up to the brain and inhibiting all pain that comes up because it's accompanied by an annoyingly cold sensation. So the third part of it, I mean, we got two different mechanisms there, but the cognitive fear part of being empowered, being able to use something that you understand, that you trust, or being able to distract yourself from pain by knowing that you've got something. If you want to go in the other room, you can grab a vibracool and put it on your knee. But if it is too much hassle to go pick that thing up, then it makes you interpret your own pain as less important because you have control over it, but you've decided to ignore it. So this whole mental pain, fear, focus paradigm is part of what we struck into when I was really just trying to replicate how to run cold water over a burn.
You talk about that pain theory and our understanding. Do you think clearly we're better at understanding it. Do we have a good handle on pain and how people sense it and how we can help control it without some of the just awful effects that we're seeing as the result of all of these opioids that have essentially been prescribed with good intentions, to be clear? I mean, I think that was the purpose, but we've got this sort of unintended, in some instances, consequence. Do we understand it better? We're in better shape now?
We understand it so much better. The question is whether or not our pharma and medical device systems are set up in a way that we can use that knowledge to help people and decrease pain. I think the three things that are the most important to understand, first is that there is not a silver bullet for pain, because pain is not just what the physical sensation is, it's how much gets transmitted and how your brain interprets it. You cannot simply have a physiologic nerve pain blocker and expect for that to accomplish everything that you need. By definition, drugs are going to wear off so that you don't accumulate too high a level. So any pharmaceutical is always going to have a period where you drop below the pain threshold of relief, and the body needs pain as a signal. So the body is always going to fight a pharmaceutical that inhibits pain by trying to get more sensitive to pain so that it can do its job and protect you. So with that knowledge, the second thing is that almost everything that's been studied for pain, whether it is vibration or drugs or magnesium or psychosocial or acceptance and commitment therapy. I mean, there's this whole, almost everything that's been studied for pain, whether it is vibration or drugs or magnesium or massage or any kind of modality, they have about a 30% reduction in pain. So if you really want to address chronic pain, even acute pain, you have to layer something that takes care of first 30%, then if you do another one, you'll get down to 52%, then you can get down to 70%, but it takes a pain plan. It is always going to take a multifocal approach to address pain. The third thing is that we now understand, really in what's been published in the last 5 years, we understand how the different mechanical receptors for stretching, light touch, deep touch, position sense, where all of those different receptors inhibit pain and why they inhibit pain. We know what frequencies work, we know what amplitudes work, and we also know that they're not just a peripheral pain reliever, they also actually seem to have central effects in the ventral tegmental area and in the anterior cingulate gyrus. So it really is this whole holistic interpretation of pain that's designed not just to keep us safe, but also to inhibit pain so we can run away from something that's not safe, or to adapt to a stimulus that's going to be continuing so that we can keep doing that and stay safe. So this bigger picture is huge, but we can't make use of this knowledge while we're not paying for mechanical pain relief. Right now, if you're a drug, you're pennies to make. There's no real cost of goods once you've been identified, and you're prescribed it for a long time. We're not paying for any of the physical devices that can address pain.
So much deeper understanding. Clearly, one of the things, it's always been sort of a little bit of an odd thing to me when we ask people to, how would you rate your pain? And, we give them whatever the scale is. And, I'm always thinking the context of that, well, that's your scale, what's my scale, and what's that relative speaking? We're very poor at assessing that, but clearly a great concept working extraordinarily well in your personal experience with your own practice. You set up a company, you went through the SBIR process to make that happen. Tell us a little bit about the journey on how that worked, and what were the key elements? What did you learn along the way? What did you what did you wish you'd known 10 years ago that would have made this faster to get to the point to where you are?
So there are a number of things that I didn't do as well, but in retrospect, I'm not sure that I would change them. One of the things is in medicine, you can come up with a cure for dead and physicians won't adopt it for 10 years. So we benefited by having a device for children's needle pain that flew under the radar and got over 30 randomized controlled trials done all over the world, but nobody has tried to rip us off or knock us off because no one cares about needle pain. And part of the SBIR process, while circuitous, allowed me to realize that there was a huge increase in needle phobia that has happened in the last 15 years. And so really in 1982 and before, anybody born before then only got 6 injections for their vaccines, and they got them before they were 2 years old, so they don't remember. Starting in 1983, we added boosters in the 4 to 6 year age range, and that's actually what correlates with the rise in needle phobia. The more injections you get on the same day when you're old enough to remember, but you're not old enough to abstract that's good for you, that is what causes people to be afraid of needles, and it's a lifelong thing. So in the year 2000, we were giving kids 36 separate injections, if you pay attention to the CDC guidelines, and children were getting 4 or 5 or even 6 injections on the same day. So that's really the pinnacle of the generation that's afraid of needles. 64% of kids born in 2000 are afraid of needles.
Wow.
So it wasn't a direct pathway from a business perspective, but the business perspective wasn't my goal. My goal was initially simply to eliminate unnecessary suffering and to improve vaccinations. Once I realized that there was a trend happening that was important, I went back to the IRB, I went back to my data, I published that. And by that time, when I published that study in Vaccine in 2017, by then I had already realized that the opioid crisis was something we could do something about. My colleague had asked if he could use Buzzy to not take any opioids after his surgery because he was in recovery. And I began really digging into the nature of prescriptions of opioids, where they fit into our teaching and our psyche as physicians, and why they were perpetuated with the current system of reimbursement. So when I had that end paper published in 2017 talking about needle phobia, I kind of felt like that was the Rosetta Stone as far as it was concerned. It was pretty easy to see the cause and consequences of not caring for pain in booster shot periods of time. And so I moved on to opioids. That circuitous track would not have happened if I had been thoroughly trying to sell the needle pain business early on or trying to build it and scale it really quickly. And the opioid understanding was something that even living with this device, even though all of us in the company would put it on our shoulders or our elbows or our knees when we got hurt, we still didn't make that leap until 2015, 2016. So would I have done that differently? I don't know that I necessarily would have. I think that we would have been a lot more efficient at getting the idea out if I had accepted investment earlier. But one of the key criteria that everybody who wanted to invest in us up until 2016 had was that we had to make the devices disposable. And without a recurring revenue model, it's difficult to get medical devices that are reusable and effective into the marketplace because there's not a real economic benefit for drug reps to go out and sell a $60 product that you can reuse.
So for those of you just joining, I'm Dr. Nick, and today I'm delighted to be joined by Dr. Amy Baxter, the founder and CEO of Pain Care Labs. We were just talking about the business journey and what I would term the adjacent possible, which was, gosh, we can apply this in needles, but now you've sort of moved to beyond that and the ability to essentially provide solutions that prevent is not the right word, but essentially help mitigate the pain in other circumstances. And that's what you've got with VibraCool, right?
Right. So I think one of the other things about this long journey was that I've had the enormous intellectual thrill of understanding our technology at the same time as research is being published, underscoring why it's effective. And so the fact that those things have happened simultaneously have enabled me to continue evolving our patent portfolio, but also being on the forefront of this really new science and technology. I mean, TENS units have been around for forever, and they have very intermittent data. So TENS units are transcutaneous electrical nerve stimulators, and they're trying to do the same thing that we do by putting pads on the skin and then with electrical current at various frequencies, twitching the muscles to twitch these motion nerves. Now, only really since the early 2000s, we're able to make motors that are high enough frequency to match the sensitive areas of these different corpuscles. You know, Pacinian corpuscles are position sense. They tell you deep position, they tell you deep touch, but they're also all around your joints and all around your motion. And they are highly effective at inhibiting pain because it's more important for your body to know where you're standing and how you move than it is once you've gotten alarmed that there's something painful. Only in the last 2017 was when this article came out that demonstrated that Pacinian corpuscles are the primary way to inhibit pain and what frequency you want. So the frequency of our devices using actual motion to stimulate actual motion receptors is far more potent as a way to inhibit pain. So it's been really exciting to understand why TENS units don't work, when they don't work, when they do work. And a lot of that is simply that in order to jack enough electricity to twitch a muscle is uncomfortable for about 50% of people. Right. Whereas motion travels in a wave, and the physics of the transmission to all of the different receptors can be configured, and it can be created to do that. So VibraCool combines the specific frequency for Pacinian corpuscles, but it also adds the very thin ice that starts that descending inhibitory pain control. And some of the ancillary benefits are that you don't have to worry about the whole do you ice it, do you not ice it, because that's just, do you mind if you decrease blood flow? Well, high frequency vibration is a sympathetic stimulator. It vasodilates. So you get more blood flow when you're vibrating, and you get the same inhibitory inflammation and the counter stimulus with the ice. So it's from a science standpoint, the fact that so much is being done and it's all new is really a tremendous place to be as an academic.
So if I was to tease out a couple of things there from sort of incremental steps and things that were significant, part of it is an advance in the technology. So you talk about the frequency of vibration, the capacity to do that. And then the other part sounds like it's the science, the advance of science. So it was never going to be a fast path to where you are now. It required those elements to come together. Is that a fair statement?
That was so much more succinct than what I said. Yes, that's nicely done, Dr. Nick. So yeah, and I think that there are even other elements that I'm not mentioning that we have had the opportunity to be on the forefront of researching, and so it's just extremely exciting. And a frustration is the word vibration itself is a tremendous barrier to making people understand. I was thinking about this recently. I think that what had happened was in 1896 was the first vibrating plate, and it was done by Marie Charcot of Marie Charcot syndrome. And so he found his Parkinson's patients did better when they'd been on a carriage or horse ride. And he presented this at the Columbian exhibition in Chicago. His student, who was Tourette of the syndrome, he made a vibrating migraine hat. And then nobody did anything with vibration until one study in 1956 looking at a vibrating bed for people who are had a whole body cast. And at that point, I think that it became apparent that the body grows and responds to mechanical strain. Because if you walk, it's a 10 to 15 hertz activity. If you pump iron, if you're lifting weights, that's how bones and muscles grow, is repetitive light strain. So you can mimic repetitive light strain with an oscillatory flywheel. And a lot of the research in the last 10 years has shown that vibration increases growth, strength, as well as decreasing pain. So the thing that happened in the field was, in 1983, Lundgren published this paper about low back pain. And after that, a lot of people tried to replicate the pain relief and weren't able to do so. So vibration got dumped into this box of quackery. The irony is, he didn't realize exactly why it worked. And so there was a specific set of frequencies in a specific place in the back that are different because they're hitting different nerves than for extremities or migraines or shoulders. And the other thing is there's an aspect of duration that matters because it triggers a different set of afferents. So poor guy to come up with the right answer but the wrong reasons, and then when people tried to replicate it because we didn't understand the science, it didn't work. Now we know why, and now we know where.
So unfortunately, we're almost out of time. And, I'm just fascinated by how long that journey is. When you think back, it's not the 10 years that you talked about at the beginning that it takes us to implement. But it seems like we're at a really exciting inflection point for the control of pain in an entirely different way, with technology that is founded on science and now good understanding of the reasons. Any closing thoughts as to where you think this will go and some of the things that are going to happen, for pain care labs?
Yeah, I like to call what we do dumb tech because it's very simple, mechanical, with a very sophisticated underscore of why. And I think that the future of healthcare in America certainly is a move toward dumb tech, because the smart tech and the connected tech is only really good if you're in the upper 5%. We've been designing for ourselves for a long time, but if we want to change healthcare and pain in America, we need to design for the middle of the bell curve, and we need things that are simple. And dumb tech is going to be a lot more effective to help everyone than Fitbits and smart tech and sophisticated electrical signals that people don't want to touch or use. Vibracool.com, paincarelabs.com, and buzzyhelps.com are our different websites. And Pain Care Labs is really the primary place to go to get to all of our different Ossilyze technology products.
Fantastic. I'm really excited about this. I think, some incredible progress, just a tremendous sort of opportunity to really change the way we think about pain and also mitigate it. It just remains to thank you for joining me on the show, Amy. Thanks for coming on.
Thanks for letting me wax poetic about my science, Dr. Nick. I really enjoyed this.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at HealthcareNOWradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.